This section is an introduction to the genitourinary system. We are going to focus on anatomy and physiology review, as well as some diagnostic testing that we do related to the genitourinary system. Now, even though this is just an overview of A and P, I always want you to be thinking about how all of this information is relevant to you as a nurse. It's important that you understand physiology, because if you know how the body is supposed to work, that helps you understand what's going on when it stops working. You want to think about what is going on with my patient right now, and is that what I would expect for this system? Or are we seeing some complications in this system that is now causing problems in other body systems? We're going to get into specific patient conditions later on, but I don't ever want you to forget that the patient is your focus as the nurse. Remember, if you understand how the body is supposed to work, you can figure out what's going to happen with your patient if the body is not working the way that it's supposed to work. You want to start asking yourself these questions of, what assessments do I need to do? How am I going to prioritize those assessments? What nursing care is this patient going to need? And how am I going to know if my patient is developing a complication? What are going to be some early signs that I start to see in this patient? As we talk about the diagnostic testing procedures, you want to think about, how do I need to organize my care before, during, and after this procedure is done? So let's begin by taking a look at the urinary system. The kidneys obviously play a key role in urinary functioning, and we're going to talk about the kidneys in a little bit. Remember, the kidneys are the ones that are doing the bulk of the work. They are responsible for filtering the blood, taking those waste products, and putting them into the urine. The urine then has to leave the kidney. It's going to leave the kidneys through the ureters, it enters into the bladder, and then it's going to be expelled from the body through the urethra. These little yellow bumps that we see here that are sitting on top of the kidney, those are actually your adrenal glands. And the adrenal glands we're going to discuss a bit more in the endocrine section. Now, even though our focus is on the urinary system, you can't forget the other body systems because our body is all connected. You need to go back and review the cardiovascular system because the cardiovascular system will have an impact on the urinary system. We need to have good blood flow to the kidneys. That's really, really important to the way that our kidneys are actually going to function because it's fully dependent on the blood flow that is going to that kidney. You also want to review the central nervous system as well as the autonomic nervous system. Remember that the nerves are going to tell us when the bladder is full. They give us that cue to say you've got a full bladder, and then we need to relax the sphincter in order to be able to release the urine and empty out our bladder. So if we don't have good neurological functioning, we're not going to recognize these cues that we need to empty our bladder. And as you're going to see as we talk about some disease processes later on, if urine just sits in the bladder, it creates stasis. And that stasis of urine actually can put us at increased risk for an infection as well as for stones developing. The autonomic nervous system is responsible for contracting the bladder so that we can empty that bladder fully as well. So if we have a problem that's impacting the autonomic nervous system, that's also going to impact our ability to empty out that bladder. You will notice in many of our diabetic patients, because they have such high blood sugar levels, it actually causes damage to some of the nerves. And so they'll develop an autonomic neuropathy, so they won't be able to get that good contraction in the bladder. So their bladder ends up just kind of sitting there full a lot of the time, and they're only able to go to the bathroom just a little bits, but their bladder still stays full. Well, that stasis sitting there just creates a nice environment for bacteria to grow. So you'll see many of your diabetic patients commonly have urinary tract infections. Here you're looking at the image of a male bladder and the surrounding structures to that bladder. Now, we are going to talk about some men's health conditions later on, but I want you to start thinking about how alterations in the prostate could impact the urinary system, for example. So if we have enlargement of the prostate, looking at where you can see that present here on the picture, you could see that that prostate gland could constrict down on that urethra. So as the prostate gets bigger, it actually constricts that urethra. That's going to obstruct urine outflow. If we have obstruction of urine outflow, the urine goes backwards, so it moves in this retrograde manner. Eventually, it could get all the way back to the kidneys and cause hydronephrosis, which is an enlargement of those kidneys from the pressure of the urine moving backwards. So sometimes it's a real structural problem that is actually causing the functional issues. But we can also have functional issues from other conditions as well. And you're going to hear me mention diabetes quite a bit because diabetes and urinary and renal problems kind of go hand in hand. Later on, we're going to talk about urinary tract infections, but you could also imagine that in addition to this movement of urine going all the way back up to the kidney, if we can't get urine out, the urine's just going to sit in the bladder, also predisposing these patients to an infectious process. Also, anytime we have stasis of urine or stasis of urine flow, that's when stone formation can occur as well. And then having a stone, that can cause an obstruction and also cause more problems. So start thinking about here's what's supposed to happen with the urine outflow, and now what could happen if we have these pathologic states, and what am I as a nurse going to be looking for in these patients? We're going to dig a little bit deeper into discussing the function and the physiology for our kidneys. So just as a brief overview, the kidney is the primary agent that is responsible for getting rid of waste products in our body. So what the kidney has to do is it actually has to have sufficient blood flow going to it. That blood is then going to be filtered. So all of our blood is moving through the kidney. It gets filtered through our nephrons, goes through the glomerulus, through Bowman's capsule, and it's going to pull out the stuff that we don't need, so the waste products, and dump that into the filtrate, which eventually is going to become urine. But what you have to remember with the kidney is that in order for this to occur, we have to have good blood flow going to the kidney. So you're going to notice that the kidneys really function as a compensatory organ for a lot of other things that go on in the body, as well as their function for filtration. The nephron is very sensitive to changes. So if we have a patient that has high blood pressure, that nephron is going to have to be involved in some compensatory actions in order to try and prevent too high of a pressure from being at the glomerulus. A similar situation is true with a patient who's hypotensive, so their blood pressure goes down. Well, they're not going to have good blood flow to the kidney, but we need good blood flow going there for their function to occur. So what we're going to see is the nephron has to respond in a few different ways in order to get that pressure back up to where we want them to be, so to a normotensive area. The work at the nephron can also be impacted by blood volume. So think about your patient who is severely dehydrated. So they're not getting very much blood flow going through to the kidney because we've got this decreased blood volume. Well, in addition to that impacting the filtration pressures and impacting our blood pressure, what's also going to happen is that if I don't have sufficient blood getting to the kidney, I'm not bringing the oxygen and nutrients that it needs to function. So our nephrons are actually going to start to die. This image shows you the overall macro structure of the kidney. Now we have millions of nephrons inside our kidneys, and the nephron is the real functional unit of the kidney. This is where all the processes that we're going to talk about next occur. And we're going to look at these processes within the context of the role of the kidneys, the function that the kidneys have within our body. Overall, the role of the kidney is really to filter out waste products, as well as to help me hold on to the substances that I actually do need, such as some of my electrolytes. We're going to go through a variety of different processes, but the ultimate goal when we think about the kidneys is that it's designed to kind of clean the plasma, clean my blood of all of these unnecessary substances. We're going to see that it's going to help control waste products such as BUN and creatinine, toxins, even all the medications that we take. Many of them have to be excreted through the kidney. We got to get rid of these toxins from our body. So in order to create the filtrate and ultimately the urine, kidneys have to engage in kind of a three-step process at the level of the nephron. So we're going to look at each of these 3 steps in isolation, and then we're going to come back and look globally at the overall function and role of the kidneys. The first step in this process is known as filtration. Filtration is going to occur in the glomerulus at Bowman's capsule. And filtration is going to be a passive process, and we're using the process of diffusion. So it's a passive process of diffusion, which means that things that are of a higher concentration, so my solutes, my molecules that are in a higher concentration, are going to move to an area of lower concentration. The second step is reabsorption. And reabsorption is where we're going to take all of these molecules that moved from the blood into the tubules, and we're going to say, hey, some of these things I need, so I'm going to reabsorb them from the tubules back into the blood. And this occurs through these tubule cells that are present. And we're going to see that both active and passive transport mechanisms are going to be used throughout these renal tubules. This is where the majority of our electrolytes are going to be reabsorbed. The next step is secretion. Now with secretion, this is where we're going to take all those substances and push them from the blood back into my filtrate, so back into that fluid that's in the tubes. Now, some of the tubule cells are actually going to secrete very specific substances in addition to facilitating the overall secretion process. This is important if we think about, we dump some stuff into the tubules. We took some of it back because we said I need it. Well, later on throughout the structure of the nephron, we say, you know what, we really don't need this. This is a waste product. Let me get this out of my body. And that's where the secretion part occurs to form this filtrate. Now, there are a lot of hormones in the body that really play a key role in regulating how much urine volume is created and then excreted. So, for example, antidiuretic hormone, ADH, that really works to regulate urine volume. It acts in the distal tubules. It also is going to act some in those collecting ducts, and that's going to increase the amount of water that we reabsorb. It's also going to increase our concentration of our urine because I'm pulling the fluid out of that filtrate, so I'm ending up with a more concentrated urine. ANH, so anti-natriuretic hormone, that comes from the muscle fibers in the heart, and that is actually going to cause us to lose sodium in the urine. Aldosterone is another example that we're going to talk about a little bit more in a few moments. This is secreted by the adrenal glands. It's going to increase the amount of sodium that we absorb in my distal as well as in my collecting tubules. And this is also going to control the amount of potassium that is secreted. What we actually end up doing is we create this kind of osmotic imbalance going on, which is going to tell us to hold on to water or reabsorb water. And we see that aldosterone kind of works in conjunction with my antidiuretic hormone. If you have a patient whose potassium levels go way up, oftentimes that will trigger aldosterone secretion because that's going to help facilitate excretion of potassium. Vitamin D is also really important when we talk about the kidney because vitamin D is what allows us to absorb calcium. And so if we don't have the activation of vitamin D going on in the kidneys, we're not going to be able to absorb calcium. Erythropoietin is another hormone. That hormone is produced by the kidneys. We see that that's going to be produced much more when our oxygen levels go down in the arterial bloodstream. And what happens is that erythropoietin is going to travel to the bone marrow, and it's going to tell the bone marrow that we need to create more red blood cells. And so I hope that as we're starting to talk about just the basics with the kidneys, that you're starting to think about, what are some things that I should be looking out for as a nurse? The kidneys do play a really big part in the regulation of pH as well. So the kidneys really help us excrete a lot of acid. But in addition to that, they also are going to release bicarbonate, and bicarbonate is my base. So you can start to think about, okay, if my kidneys aren't working, and I'm not excreting out a bunch of acid, and I also can't make a base to kind of buffer the existing acid, my patient very quickly is going to become acidotic. So we really need to kind of look at that when you're thinking about kidney function. So really start to think here about, what about you have a patient that has kidney failure? What are they not going to be able to do? And what might you see as an assessment finding with this patient? Let's look in a little more detail at the renin-angiotensin-aldosterone system before we jump back into talking about kidney function. So renin, or renin, is an enzyme that is going to be secreted by the kidneys, and it's going to really help out with the regulation of sodium retention. So this is also going to impact blood pressure and fluid volume. So the way that this system works is it's going to eventually end up with angiotensin II. So we have the liver. That liver is going to release angiotensinogen. Renin, which comes from the kidney, is going to be released, and that is going to facilitate the conversion of angiotensinogen into angiotensin I. Now this is going to be released, your renin or renin is going to be released if I have decreased blood pressure or I have decreased fluid volume. I can also see if I have a drop in my sodium level, that may also trigger the kidneys. When I have angiotensin I, I need to convert it into angiotensin II. So angiotensin converting enzyme is going to be released from the lungs to facilitate that conversion. When we get to angiotensin II is a very potent vasoconstrictor. So we're going to see that those arterioles are going to constrict way down. And that constriction is going to cause your blood pressure to go up. However, angiotensin II is also going to trigger my adrenal glands, so specifically the adrenal cortex, to release aldosterone. Aldosterone is going to go back and act on the kidney. Aldosterone is going to tell the kidney, you need to hold on to sodium, and then that causes me to hold on to water, which is going to cause my blood volume to go up, and by increasing my blood volume, I increase my blood pressure. So what you can see with the kidney is the kidney really plays a significant role in our fluid balance that's within our body over time. So let's revisit some of these functions of the kidney. Remember, the kidney is going to play a key role in filtration and fluid balance. So the kidney is responsible for getting rid of our excess sodium, potassium, chloride, magnesium, calcium, a whole bunch of different electrolytes. And so if the kidney fails, some of these are going to go up. We're going to talk about how that's different with calcium in just a few moments. But many of these, if my kidney's failing, my potassium level is going to go way up, which is a big concern for me because my body can't excrete the potassium. Magnesium is another one. It's almost exclusively excreted through the kidneys. So if your kidneys are failing, that magnesium level in your blood is going to go way up. Keep in mind your kidneys are working 24/7, so all day and all night they are working to filter your blood. The kidneys play a big part in maintaining our fluid balance. They're deciding, do I hold on to water? Do I dump water? They are also working to filter out waste products. Now, the two main waste products that we are concerned about are the BUN and creatinine. The BUN, or the blood urea nitrogen, can be impacted by a lot of different things. So while we do look at this value, it's not as important to us as creatinine. You may remember from A&P that a byproduct of protein metabolism is ammonia. And the liver is supposed to get rid of ammonia by taking ammonia and converting it into urea. And then the kidneys take over by filtering out the urea, putting it into the filtrate so that it is excreted in the urine. So we really shouldn't have high ammonia levels in the urine because the ammonia is supposed to have been converted into urea by the liver, and then it's the urea that's being excreted. However, it's the kidney's job to get rid of the urea. So if the kidneys are failing, then what do you think may happen to your urea level? Well, that blood urea nitrogen level is going to go up. However, your BUN is impacted by a lot of other things, so we can't look at it just in isolation. For example, if you have a ton of protein intake, Well, that's going to take some time for your body to process all of that protein. So we're going to have a higher BUN. Also think about if your patient is bleeding. Let's say your patient has a GI bleed, goes into the stomach, goes into the intestine. Now I've got all this excess protein that has to be processed. That's also going to cause a rise in that BUN. We can also see how well our heart is working. That could also impact our BUN levels. So if my heart isn't pumping as effectively, we're going to see that the BUN is going to go up because your patient is going to have poor perfusion going to those kidneys. So we're not going to be able to get rid of those waste products. And when you think about dehydration also, that's going to cause the BUN to elevate because the kidney is going to want to retain the water, but we have a decreased amount of blood volume. So it's going to look artificially like that is elevated. So it's not really as good of an indicator in isolation. The creatinine level is going to be a much greater indicator of kidney function. Creatinine is much more consistent. So that's why we use it as a better indicator of kidney function. We're going to have this more consistent or constant value within our bloodstream, and it's not really affected by that much. Creatinine is a byproduct of skeletal muscle metabolism, and that's why it's just very consistent throughout the body because we're always engaging in this kind of continual metabolism of that muscle over time. Now, obviously, if you were in a severe car accident, you had a massive crush injury, severe trauma to those muscles, certainly we're going to have kind of greater metabolism there. But in general, that creatinine level is going to be nice and consistent. Remember, when we talk about the kidney, we're also looking at fluid balance. So the kidney really is trying to decide how much water it wants to hold on to or dump. And a lot of this is going to depend on cardiovascular function and how much perfusion the kidney is getting. So if I have a lot of pressure going to the kidney, I'm going to be losing fluid. I'm going to be dumping more fluid in the urine. If I don't have as much pressure going to the kidney, then I'm going to hold on to fluid. The kidney is also really responsible for helping with that acid-base balance as we talked about. So remember that the kidney is going to get rid of the acids that were not blowing off when we're talking about CO2 being released when we exhale. That's coming from respiratory function, but many of my other acids are actually going to be excreted through the kidney. And so if the kidney's not functioning, we're going to see that all those acids are going to go up. You also may remember that the kidney plays a big role in the creation of bicarbonate. Bicarbonate is going to work as a buffer with acid. Well, the problem is that if the kidney is failing, now I'm retaining acid because I can't excrete it, but I'm also not able to create that nice buffer, that bicarbonate base. So both of those things combined are going to keep your kidney failure patient in a state of metabolic acidosis. The kidney plays a role in blood pressure regulation as well. So if we don't have sufficient pressure going to the kidney, we can't produce urine. We've got to have good perfusion of the organ in order for that filtration process to occur. So oftentimes, if we want to try and get kind of an estimation of my patient's cardiac output, we'll take a look at our patient's urine output and see how those pair together. The kidney itself does have some ways that it can kind of increase pressure to itself if it needs to. There's some internal formulations, but there's also a renin, which we mentioned previously. That system can play a role. When the pressure drops, we're going to release that renin, and that's going to trigger that conversion all the way down through to angiotensin II. So renin facilitates the conversion from angiotensinogen into angiotensin I. ACE is going to facilitate the conversion of angiotensin I into angiotensin II. We get that potent vasoconstriction. Blood pressure goes up. We also are going to trigger the release of aldosterone from my adrenal glands. Aldosterone goes back to the kidney, that's its target organ, tells the kidney hold on to sodium. We end up holding on to water. That increases my blood volume, which increases the blood pressure. Another interesting function of the kidney that we have to talk about is the role that the kidney plays in relationship to calcium. Now, we do know that the kidney is responsible for excreting calcium, but the kidney also plays a really unique role in activating vitamin D so that we can absorb calcium. So if we don't have activated vitamin D, we won't be able to absorb calcium in the first place. So I want you to think about your patient who is in renal failure. If they're in renal failure, we cannot activate vitamin D. If I can't activate vitamin D, I can't absorb calcium. So my renal failure patient's calcium level is actually going to go down because they're not able to absorb it in the first place. Now, as you may remember from chemistry, if my calcium levels are going down, my phosphorus levels are going to have the opposite effect. They have what we call an inverse relationship. So the phosphorus levels are going to go way up in your patient. And we're going to explore this concept a little bit more when we get into some of our endocrine conditions. Another important role of the kidney is in the synthesis of erythropoietin. Erythropoietin is a hormone, and the target is the bone marrow. So when we release erythropoietin, it goes to the bone marrow and it stimulates that bone marrow to produce red blood cells. So in a patient that has kidney failure, they're not going to be able to release that erythropoietin, so we're going to see that they often develop anemia. And this can be mild to extreme anemia depending upon their kidney state. So let's think about the nursing assessment for a moment. I've got a patient that has some type of urinary tract disorder, perhaps they have some type of renal disorder, and we need to engage in an assessment. Well, I need to have both subjective and objective data. So I want to explore their health history. Have they ever had problems in the past? Let's see, what is their typical pattern for urination? Do they go long periods of time without voiding? Are they voiding more frequently, but they don't get as much out? Have they had a history of diabetes or hypertension? What kind of medications are they taking? Remember, my job, my kidneys, is going to be to filter out toxins. Medications that we take are basically poison. So the kidneys, in many cases, are the ones responsible for filtering all those toxins out. And some of those toxins are really harmful to the kidney. Have they recently had surgery? Surgery has a huge impact on our urine output and our hydration status. You want to go through your whole functional health patterns, so those don't go away. We still have to ask all of those functional health pattern questions. How are they living day to day? How much water are they taking in? What kind of exercise do they get? Are they getting up all night to go to the bathroom, but maybe they don't void much during the day? So all of those are really important questions and things we need to dig into within the subjective data. When we look at the objective data, or looking at our physical assessment that we complete, we definitely want to look for fluid and hydration status. So there really are 5 big things that we want to look at when we're looking at fluid or hydration status. So you do want to get daily weights on the patient. We want to make sure we're monitoring I&O as closely as possible. You want to check for skin turgor, check their mucous membranes, and get a series of vitals. We really want to make sure we're listening closely to their lungs. Somebody that's in volume overload, you're going to hear crackles in their lungs, and so that's going to be an important assessment to complete. We also want to look overall at their skin. Do they look edematous at all? Is it pitting? Is it non-pitting? We're trying to discern between, is my patient in a fluid volume excess? Do they have a normal expected fluid volume, or are they in a fluid volume deficit? And we're going to talk about some diagnostic tests a little bit later that are going to give us some additional information about the functioning of the urinary and renal system. These are just some general manifestations, so general signs and symptoms that we may see in a patient that has renal or urologic disorders. So this is not a list for you to memorize at all. This is not true for every single condition, but these are just some things that we may see when we start to engage in an assessment. So if a patient mentions that they've had a fever, if they mention that they're extremely swollen, that's coming from a volume overload state, those might be clues to us that we need to engage in a focal urinary assessment. So the pain, we think with patients that have kidney stones, they are in excruciating pain. Patients that have urinary tract infections will experience pain as well. If they have hematuria is blood in the urine. We should not have blood in the urine. If they do, particularly if it's painless, so there's not pain with it, we're concerned about different types of cancers, your bladder cancer, your renal cancer, if we're starting to see blood in the urine. If they develop oliguria, oliguria is when they have less than 400 milliliters of urine in a 24-hour period. So that means they really are not doing sufficient output. There's not sufficient function of those kidneys, versus anuria where we have no urine output. A lot of our end-stage renal disease patients, they're not going to be producing much urine. We're going through dialysis, which is a process we'll talk about, so they won't be producing much urine at all, so they would be considered anuric. If my patient has a urinary tract infection, they may or may not have a fever. If it's going all the way up into the kidneys, then I may be more likely to see a fever. Your dysuria, that is just kind of pain with urination in addition to having some trouble overall with being able to urinate. A fairly classic sign with a urinary tract infection, as long as we have functioning nerves to sense that. You could see some pus in the urine, you could see bacteria in the urine, and a lot of different electrolyte imbalances. So again, not a list to memorize, just something to keep in mind that if I see these signs and symptoms of my patient, I need to dig more into doing a focal renal or urinary assessment. We have a variety of diagnostics we can use. We've got some tests we can do on the urine, as well as those that we can do on the blood or the serum. If we're doing a urinalysis, that's looking at the urine. What color is it? Is it clear, pale yellow, amber? Should be mostly water. May have a slightly faint smell or aromatic smell to it. Really should not be strong smell of ammonia though. So that's why it's so important when we get these urinalysis tests done, we send it right to the lab. You do not want that sitting around for a while. There shouldn't be any protein, glucose, ketones, nothing like that in there. It should be sterile, so there should not be any bacteria. A lot of that is dependent upon if we did good teaching or not and how to collect the specimen or the route that was used to collect the specimen. We could do a culture on it, so we send it out for a UA and a culture, so they're going to culture out to see if there's any growth of microorganisms in there, and then if we're looking for bacteria, they may do a sensitivity test at the same time, which is where they're looking to see what antibiotics are going to be the best to use that bacteria is going to respond to. They may order a 24-hour urine collection. What we're really looking for here is what's called a creatinine clearance. What we're trying to see is how well the patient's able to excrete creatinine and how much is actually staying in the blood. So you've got to make sure that they have a nice dark container that you'll get from the lab that we're going to use. The patient is going to void. We want to make sure empty their bladder as much as possible. And then we're going to say, okay, our start time is now. So that first void is not going into the specimen container. That first void is dumped. Then they start their timer, and then the next time they void, all of the urine that they go in all the way through for the next 24 hours is going to be collected. If we miss anything at all, we have to start all over again. So it's important that you take the time to educate your patient on this procedure. They're doing it at home. You also have to make sure they understand that they need to keep it in a cool environment. So it should go in the refrigerator. In the hospital setting, you often see it placed on ice. If they've got a Foley bag, that's got to be placed on ice as well. And you got to empty that frequently so that we can get it all into that container. That's that dark kind of container to protect that urine. When the 24 hours has completed, we will have the patient void one more time, and all of that will go into the collection device, and then they will take it to the lab at that point. This test is one way that we can kind of get an estimation of our patient's glomerular filtration rate, which we're going to talk about a lot more in another section, but it gives us kind of an idea of what degree of kidney disease that our patient may have. Sometimes we can just draw serum creatinine level, and the lab will kind of estimate what our GFR is based on that test, but it's not as accurate as the creatinine clearance test. So if my patient is starting to have an increased risk of kidney disease, so let's say that they're a diabetic and it's not really well controlled, they are consistently in a volume overload state, maybe they have uncontrolled hypertension or poorly controlled hypertension, those patients would be ones that would benefit from doing the more accurate creatinine clearance test. In general, the male and female have a fairly similar GFR. It's slightly different. We're going to look at kind of some general values when we talk about this. In our renal failure section, we're going to use kind of 60 to 120 mils per minute as our main focus rather than dividing it male versus female. But it is important to know that while similar, there is a slight difference between those two. Additionally, as we age, our creatinine clearance is going to go down. So usually for every decade after the age of 20, our creatinine clearance is going to go down by about 6 to 7 milliliters per minute. A residual urine is another test that we can do. This is where we are going to have the patient empty their bladder. And then after they empty their bladder, we'll go in and do a sterile straight cath procedure to see how much is actually left in the bladder that they weren't able to void when they thought they were completely emptying their bladder. Sometimes they'll do less precise residual urine tests, which is where they use a bladder scanner, but that is not considered precise. That is just an estimation. So if you want a true residual urine, they do have to do a cath. Sometimes our patients that have prostate enlargement, because there is obstruction, that compression on the urethra, they're not able to get out all of the urine that's in their bladder, so they are usually good candidates for this residual urine test to see how much is actually left still in that bladder. We have a variety of blood tests that we can do as well. We have already talked about the BUN and the creatinine. Again, your creatinine is going to be the more reliable indicator of a change in kidney function. We also can take a look at our patient's uric acid level as well as their electrolyte levels. There are some other diagnostics that can be done. We can do a KUB, which is an X-ray of the kidneys, ureter, and bladder. We can do an IVP. An IVP is where we start an IV and we inject a contrast media, so we inject a dye, and then we go through and do a series of x-rays in kind of a serial fashion, and that helps us really to visualize the urinary tract. The challenge is that the dye, that contrast media that's used, is very toxic to the kidneys. So if a patient already has reduced renal function, this will not be a test that they would be a good candidate for. If our patient is getting this test or is planned to get this test, we do have to do an assessment of kidney function first, and then also determine if they have any allergies such as to iodine. Sometimes if there's sufficient time, they'll do a bowel prep for them. So if we clear out the bowel, it really helps with getting a much better visualization of what we're looking at with the urinary tract. And then afterwards, as long as it's not contraindicated, we're going to force fluids. So we want this patient to have lots and lots of fluid. We want to flush out all that contrast, make sure they're having good urinary output. We can do a cystoscopy as well. So you may see that the healthcare provider decides that a cystoscope is needed so that we can go inside the bladder with this scope that has a light on it. We can see, really get a good visualization of the bladder. Sometimes this is also done if there is assistance needed in a special procedure to insert a catheter that's going into the ureters there. They do have basket procedures that can be done along with the cystoscopy, which is where if somebody has stones and they can visualize the stones, they can take this little basket and kind of go up and pull them out. That's a procedure that's been around for a long, long time. It also, if we can go in and see areas where there may be bleeding, we could go in and the healthcare provider would go in and work on treating or cauterize some of those areas that are bleeding inside there as well. Usually your patient is going to be under either a local or general anesthetic throughout that procedure. Making sure that your patient really understands what's going to happen both before and after the procedure. So after they've had a cystoscopy done, usually they'll have some burning on urination. They might even have some kind of pink tinged color to the urine. And so sometimes, depending upon how much planning they have, they may actually put the patient on prophylactic antibiotics for a few days before they do the procedure. It's not done by everybody, but it is a possibility that you may see. Right after the procedure, so immediately after the procedure, we have to be really, really careful that we're mobilizing our patient in a safe manner because they can develop orthostatic hypotension. You might also see that your patient needs to go in for a renal biopsy. So this is where they're taking a piece of tissue from the kidneys. They're going to try and examine it. See, does my patient have renal disease present? If so, what kind of progress are they making in that disease? Are we progressing to later stages? They may be looking for a whole host of different things when they're doing this type of procedure. So what they're doing is they're actually going to go through the skin, so it's percutaneous. and they're going to insert a needle that goes into the lower lobe of the kidney in order to collect their sample. And so you have to be really, really careful when this procedure is being done on one of your patients. If they have a kidney infection, or they already have a really enlarged kidney, so they have hydronephrosis, or if we think that they've got some lesions growing there that are highly vascular, that can be really dangerous to perform this procedure, because bleeding is a huge complication of the procedure. So we really want to have a good understanding of what my patient's bleeding times are, what medications they've taken recently. So were they on heparin? Were they on warfarin? Do they take aspirin every day? How is their blood pressure being controlled? So these are things we have to really look at. And if they only have one kidney, in general, they will not do a renal biopsy because of the concern of what if we damage that one kidney that they have left. So we will also see that they'll type in cross them for blood because it is a concern for bleeding before the procedure. When the procedure is done, again, my focus is bleeding. I'm really concerned about blood loss. So usually for the first hour or so, they will really focus on good positioning in order to put the patient on the side that had the biopsy done on, because that adds pressure. And if I add pressure to that site, that's helping me to reduce bleeding. I'm helping to form that clot and starting that clotting cascade. We always want to talk with our patient, make sure that they're not experiencing any flank pain. You want to check their blood pressure, make sure their blood pressure is stabilized. You do want to look out for any change in their temperature. They have chills, or they have difficulty urinating. Sometimes what we'll see is they'll order UAs a bunch because they want to see, are we having any more hematuria? They might just say just dipstick the urine. So you're always looking for bleeding there. And then for a week or so after the procedure, they recommend that the patient doesn't do any heavy lifting. We don't want them on anticoagulants because we're really concerned about bleeding. But again, that will all be decided individually based on the patient's situation and the healthcare provider's decisions. So we have finished the introductory section, and we're going to take all of that information that you just reviewed, and now we're going to apply it to caring for patients with a variety of different conditions. We're going to look at some urinary conditions, kidney conditions, as well as a few men's health conditions as well. I'm looking forward to seeing you in the next sections.